Now that you completed the compendium, we're going to dig deeper and provide you with even more knowledge on spectral tracking. Now, what is the idea behind packing two courses into one? First, with the compendium, we want to give you a quick head start so that you can already use spectral tracking in your practice. By going through the compendium, it will be easier for you to understand the complexities of the method that we're going to show you in the advanced section. In addition, we also want to bring together the experience from experts in the field from around the globe so that you can learn the many different aspects of spectral tracking. In the advanced section, we will explain issues such as how to interpret curves, how different vendors tackle the analysis process, and we'll also expand on other pathologies and show you how you can use spectral tracking for the right ventricle and the left atrium. Of course, we'll also provide you with many case examples to help you better understand the information we gain from spectral tracking. We're also going to give you a section where you can see the cases which we showed you in the lectures with additional cases which you want to update. So enjoy and have fun and learn from the best heads in the field.
So spectral tracking as an eye-opener, as an insight into the cardiac mechanics has been hugely instrumental in giving us that additional information which we always wanted.
Myocardial mechanics, a very important topic. In the first part of the masterclass, we already showed you the fundamentals. Now we'll go deeper into this topic, and I'm very happy to have Jens Uwe Vogt with us, who is the head of the imaging department at the University of Leuven. And as a matter of fact, without Jens, we wouldn't be using spectral tracking because he was instrumental in developing this technique in the first place. So welcome, Jens.
Thank you very much, Thomas. So let's talk about myocardial mechanics. The heart is really a hard-working organ. It pumps per beat only 70 milliliters. That doesn't sound a lot. But when we sum it up over the day, we end up with 7,000 liters per day. And over a year, it becomes 2,500 tons. This is really impressive. And the key element that performs the pump function is the sarcomere. You know, the sarcomere exists of actin and myosin filaments. And these filaments have these little heads that build cross bridges that actually produce the force. And the force that is produced is rather little. It's only 5.3 piconewtons per cross bridge. However, if we have a lot of cross bridges in a filament, and if we have a lot of filaments per square centimeter of muscle, then we can produce quite a bit of force, and the myocardial muscle can produce around 30 newtons per square centimeter, which is equivalent of 3 kilograms per square centimeter. The actin-myosin filaments shorten the sarcomere, and this sarcomere shortening is around 5 to 10%. So how can it come that the left ventricle actually changes its volume by 60% during a beat? This is due to the myocardial fiber architecture. This is a rather complicated way of arrangement of the myocardial fibers. You can see it here in this diffusion tensor imaging. This is an MRI technique that shows the fiber orientation. And you can recognize that the fibers are oriented in a spiral way. I have here a more schematic drawing. There are two major spirals which run in the opposite direction. And as a result, the myocardium deforms in a very complicated and a very complex way. And I've tried to show you here the deformation by means of cutting out a piece of myocardium out of the left ventricle. And to make the description of the deformation easier, we distinguish three major directions which are actually aligned with a major axis of the left ventricle. We distinguish the longitudinal shortening and lengthening, the circumferential shortening and lengthening, and the radial thickening and thinning.
But Jens, how do we actually describe myocardial function?
For that, we go best back to the sarcomere and look how it shortens. We have three basic parameters that we can use to describe that shortening. Once, there is the length change. So we see that the length of the sarcomere changes a certain bit. Then the sarcomere is producing a force, of course. And the third parameter is that the sarcomere shortens with a certain velocity. However, these three parameters are not so easy because they are not independent from the geometry of the muscle. So what we should consider is if we make a chain of sarcomeres, then these parameters change. For example, the length change becomes 3 times as much if we add 3 sarcomeres. Or the velocity of shortening becomes 3 times as high if we add 3 sarcomeres. So this is not so good for describing function. The same happens to the force development. If we put sarcomeres in parallel, then the force production, of course, is higher than if we have just one sarcomere. So we should do something to normalize these parameters. And let's think how we can do that. We would like to normalize the length change to the baseline length of the sarcomere. And we would like to normalize the velocity of shortening to the baseline length. And the force that is produced, of course, has to be normalized to the cross-section. And when we think of these 3 types of normalization, then we end up actually with the parameters that we all know, which is strain, stress, and strain rate.
So it's actually not that easy. Would that also mean that if you have a myocardium which is thicker, then you can create more force?
Yeah, I think that's exactly the purpose. That this is a compensatory mechanism of the myocardium to handle a higher wall stress.
To explain why this is important in a clinical context, let's go back to an interview with Jens Uwe that we recorded earlier. But what about the entire geometry of the ventricle?
Certainly, it also plays a role. Usually the geometry of the ventricle changes due to an adaptive process. And if you have thick walls, then the reason is maybe a high afterload. So the ventricle has to somehow cope with that. And if the walls get thicker, the point is that the single myocardial fibers don't have to work so much anymore because the work is distributed over more myocardium, and therefore they contract less and the strain gets lower. So just the fact that the myocardium gets thicker explains quite often already that the strain goes down.
The heart is not a 2-dimensional structure. But then how do we look at strain in 3 dimensions?
So, and if we now convert this from this 1-dimensional deformation to a 3-dimensional deformation in the ventricle, then we do not talk about length and length change, we do talk about volume changes. And instead of force, we are talking about pressure. And instead of the velocity of shortening, we usually look at the velocity of the pressure rise inside the ventricle. What is important to realize is that all these parameters are load dependent.
What do you actually mean by load dependence, and how is that important in clinical practice?
That's a very good question, Thomas. I would like to illustrate that here in this example. This is a single myocardial muscle, and this muscle is trying to lift a weight. And here in these diagrams, I show you how the force development in the muscle is and how the length change of the muscle is. And what you can see is that there's first force development, and when the force is high enough, then the weight is lifted. And at that moment, the muscle starts to shorten, and this can be seen here. And then we have the third parameter we were talking about, and this is the velocity of shortening, and this is basically the steepness of this curve here. So, and what happens now if we change the load, if we make this weight heavier? So let's simply double that. And you see that all these parameters change. So if we increase the load on the muscle, then the muscle has to produce more force. You see this curve going up. And the velocity of shortening and also the peak shortening goes down. So all these 3 parameters depend on the loading conditions.
So basically, if we have a patient with aortic stenosis, it takes more force to initiate ejection, right, and it probably also takes longer until you reach the peak velocity.
Exactly. This is what we see when we look at the outflow tract, look at the flow signal in the outflow tract. We see that the peak comes a little bit later if there is a higher afterload. So what I described here is a 1-dimensional representation of the parameters that describe loading changes. In the heart, we have 3 dimensions, and therefore we use the 3-dimensional parameters. So we look at volume changes and we look at pressure changes. And you probably all know these pressure volume loops from your physiology lectures. We have in these loops the volume change on the x-axis, and we have the pressure change on the y-axis. And if we now change the loading to the cardiac chamber, then these loops change their shape. And what we use to describe myocardial function is that we look at the steepness of the end-systolic pressure-volume relation. So this steepness describes what we call myocardial contractility, and this is the invasive gold standard for the assessment of myocardial function. Contractility can change, of course. For example, due to medication, we can give a beta blocker and contractility goes down, or we can give dobutamine and the contractility goes up, and likewise the steepness of the end-systolic pressure-volume relation goes up or down.
So how do we put this into a clinical context? How do we actually look at global left ventricular function in clinical practice?
Yeah, that's a good question, because of course we cannot measure contractility invasively by putting a catheter in each patient where we want to know myocardial function. So what we have are rather simple surrogate parameters, and let me start with the first parameter that everybody knows, that's ejection fraction. Ejection fraction is a volume change of the chamber. So we look at the volume in end systole and end diastole. That's calculated according to the Simpson's rule that you all know. And then we make the relation between the stroke volume and the end diastolic volume and call that ejection fraction. This ejection fraction, or this percentage left ventricular volume change per stroke, is a very good and very well established surrogate parameter for myocardial function, and it's actually a key figure in cardiology. And there is no single echocardiographic report that goes out of the lab without ejection fraction. And it's supposed to be a good estimator of myocardial performance and also patient prognosis. And it has another advantage, because we can basically measure ejection fraction with almost all imaging modalities. We can measure it with echocardiography, we can use contrast in the cath lab to show the cavity, we can do it in the CT, in the MRI, and even the scintigraphy we can measure the volume change of the left chamber. However, it's a surrogate parameter, so we should be aware that ejection fraction is not contractility. And it can fool us. And a very good example is a patient with a huge regurgitation. And if you look at these images, you see that there is a big aortic insufficiency. And the ejection fraction looks quite good still, but this is already myocardium that is damaged, because it should contract much, much more if you have such a huge regurgitation. And this is another example here. This is a dilated cardiomyopathy. And I gave dobutamine to this patient, just a little bit of dobutamine, to see if the contractility changes. And what you can see is that indeed the heart is starting to move more vigorously. So it's contracting more on the septal side, it's contracting more on the lateral wall, but the ejection fraction doesn't change at all. So there are diseases where ejection fraction is not equivalent to myocardial function.
I think we talked about many of the pitfalls of ejection fraction in the first part of the masterclass, and I think this just complements again the limitations. So what do you think we should actually do then if ejection fraction is not optimal?
First of all, we should do ejection fraction. So if we look at the guidelines, and these are the latest recommendations from both imaging societies in Europe and in the States, ejection fraction is still the recommended parameter for assessing myocardial function, and they recommend to do that with the biplane Simpson method. But of course we have new parameters. We have, and this is the masterclass about deformation imaging, we have deformation imaging derived parameters like strain imaging. And one of these parameters is global longitudinal strain. Global longitudinal strain describes the myocardial length change parallel with the endo, mid or epicardial contour of the ventricle. And this length change is around 20–21%.
But what does this deformation parameter have in common with ejection fraction?
These are both deformation parameters, and when we look again at the sarcomere, we are describing there in one dimension the strain as the relative length change relative to the baseline length. And when we go to 3 dimensions, we describe a volume change of the chamber, and this is also just a volume change relative to the baseline volume. So actually ejection fraction and strain are not really different. It's just a one-dimensional measurement and a three-dimensional measurement. And it's just a slightly different way we write it down. And when we correlate both parameters, we see that they correlate with a factor of 3 usually, but this correlation is not perfect. And this is probably due to the fact that both parameters do not exactly measure the same.
What exactly is the difference then?
So the difference is probably that longitudinal and circumferential function are measured by the ejection fraction, because we contour the ventricle and both the inward motion of the contour and the shortening of the ventricle are mirrored in this number. While when we look at the global longitudinal strain, then we are mainly looking at the longitudinal function of the ventricle. So therefore, both parameters show us different things. I brought you an example here. This is a patient with an aortic stenosis. And although this patient has a completely normal ejection fraction, the strain is already severely reduced. It's a strain of around -16%.
Does that mean that the longitudinal function is the one that fails first before all the other parameters fail?
It looks like it's a bit more sensitive indeed. I brought you here another example where you can see this discrepancy between ejection fraction and longitudinal function even more. Particularly in hearts which have a thick myocardium, we see these differences. So this is a patient with a hypertrophic cardiomyopathy on the left side and a patient with an amyloidosis on the right side. And you see that the ejection fraction is rather high normal or more than normal, but the longitudinal shortening of both hearts is reduced. So we actually have done a study and we looked into this relation between thickness of the walls and longitudinal shortening, and we found that there is indeed a relation. The relation is not perfect, but it's rather strong. It's in the range of 0.5, but there is also other things that influence longitudinal shortening. So when you look at this graph, that's the relation between the hypertrophy and the shortening. And if we add to the hypertrophy also the pathology, the underlying pathology in the model, then we see that this correlation between the two improves. So we can explain longitudinal shortening changes not only by the thickness of the myocardium, but there is also something that comes from the underlying pathology.
Just as a question for my better understanding, so basically if you have an athlete, he does not have a pathology, he has a physiologic form of hypertrophy, his strain would also be reduced?
Yes, you will most likely see a reduced strain in this athlete as well, yes. And we have compared strains and ejection fraction in patients with cardiac amyloidosis, in patients with hypertension, and in patients with hypertrophic cardiomyopathy. And actually we tried to calculate the ratio between the ejection fraction and the global longitudinal strain. And we found something very interesting, because that this ratio between ejection fraction and global longitudinal strain is higher in patients with cardiac amyloidosis than in other forms of hypertrophy like the hypertension or the hypertrophic cardiomyopathy. And we found a cutoff of around 4, which distinguishes these groups.
So in other words, we have a divergence between the ejection fraction and strain in under certain conditions.
Yes, and this divergence between the two can be rather extreme. Actually, I've brought you another case, and maybe we should have a look at it.
Yes, I think definitely we should take a look at that case because it's so spectacular, I've never seen it myself.
The case I brought with me is a case of a 35-year-old male, and this patient has a non-compaction syndrome. And I show you here the black and white images, the short axis and the 4-chamber view. And as you can see, the global myocardial function is severely reduced.
Well, how high would you think ejection fraction is?
We can measure it. So I've measured the ejection fraction with AutoEF, and you see here that the ejection fraction in the 4-chamber view is 20%.
But Jens-Uwe, can you show us the strain now?
Yeah, the strain is really surprising. When we look at the strain images from this patient, then we see, although this patient is obviously alive, the heart is beating, we have a global longitudinal strain of 0.
So can a patient actually be alive with the strain of 0?
Obviously.
Yes. So certainly a case I have never seen before. So after this case, let's summarize what we've learned so far.
So I think what is most important that you should know is that the contractile state of the myocardium, or what we call contractility, is something we can only measure invasively. For the complete description of contractility, we need to know not only the deformation of the myocardium, but we also need to know the loading conditions, and therefore with non-invasive imaging we cannot measure contractility directly. We can only use surrogate parameters. But for clinical use, echocardiography offers a variety of very valuable surrogate parameters, such as the ejection fraction or the global longitudinal strain. And I think I could show that global longitudinal strain measurements are robust and reproducible and offer an added value compared to ejection fraction.
So thank you, Jens-Uwe. I think a very important topic, and this will serve as the fundamentals for the understanding of much which is still to follow.